So good morning and welcome to our public event on virtual dementia care during the COVID-19 pandemic and beyond. My name is Ruth Kruger and I'm the Knowledge Translation and Stakeholder Relations Lead for ONDRI, the Ontario Neurodegenerative Disease Research Initiative. We're putting on this educational session today in partnership with the Alzheimer Society of Ontario. We work closely with the Alzheimer's Association, along with other charity and advocacy organizations representing the 5 disease groups that we study through ONDRI. We want to thank Alzheimer's for working with us on this event today, and on behalf of both of our organizations, we welcome all of you. Here's our agenda for today. We'll begin with Dr. Sara Mitchell, who will talk to us about a research paper she co-wrote with some colleagues entitled Virtual Care for Patients with Alzheimer's Disease and Related Dementias During the COVID-19 Era and Beyond. This paper was published in the Canadian Medical Association Journal. Dr. Mitchell will also expand on her personal experiences in treating her diverse dementia patient population, along with some thoughts on the future of this type of care. I'll have a bit more to say about Dr. Mitchell and the rest of our presenters shortly. Next, we'll hear from Christina Stergiou, who will tell us a bit about some of the unique programs that the Alzheimer Society of Ontario offers today. While all of these programs were offered in person in the past, some have had to pivot a bit during the pandemic. And finally, we'll feature Dr. Richard Schwartz, who will tell you a bit about ONDRI and our place in brain research, with a special focus on HANDDS Ontario, a new research study that we're launching shortly. HANDDS Ontario will take place largely in participants' homes and community, utilizing leading-edge remote health monitoring technologies. More to come on this. We'll finish off with a question and answer period where we'll address any questions that you have, although we'll try to address these throughout today's sessions as well, and you can feel free to put your questions in the chat box as we go. But first, because the picture says 1,000 words, I thought I'd show you a slide that features some preliminary data gathered by our ONDRI AIM4 team. This is work that's carried out in partnership with ICES, a research organization that has access to the vast and secure array of Ontario's health-related data. The figures show rates of family physician and neurologist visits among community-dwelling people living with dementia. And then we see Parkinson's disease, and then older adults, age 65 and older, without neurodegenerative diseases in Ontario. So this includes information from over 130,000 Ontarians with dementia, 30,000 individuals with Parkinson's disease, and 2.3 million older adults. The figures compare rates of physician visits during the 2020 COVID-19 pandemic, starting on March 1st, 2020, and they compare these figures to all of 2019. The solid blue line represents the total physician visits during 2020, while the dashed line represents total physician visits in 2019. Virtual visits are shown in lighter blue shading, with in-person visits in the darker gray. What's showing is that family physician and neurologist visits declined during the first wave of the pandemic in all groups, but rebounded to levels modestly higher than those seen historically for most of the categories. Visits rapidly shifted from in-person prior to the pandemic to virtual care during the pandemic, as shown by the larger, lighter blue area. Very interesting data. And now to our speakers. We're pleased today to feature Dr. Sara Mitchell. Dr. Mitchell received her medical degree from McMaster University in Hamilton and completed her neurology residency at the University of Toronto. She then completed a fellowship in behavioral neurology and neuropsychiatry through Harvard Medical School and Massachusetts General Hospital in Boston. In addition, Dr. Mitchell received her master's in public health, focusing on clinical effectiveness from Harvard as well. Dr. Mitchell works as a staff neurologist at Sunnybrook Health Science Centers, and is an assistant professor in the Department of Medicine, Division of Neurology at the University of Toronto. Her research interests are focused on quality and innovation in care delivery to patients with complex brain diseases, with a special interest in virtual care. Our second speaker today is Christina Stergiou-Dayment, who completed her master's degree in social work from the University of Windsor. Christina is a senior director of provincial programs and partnerships with the Alzheimer Society of Ontario. A healthcare professional with experience working across community, hospital, and long-term care sectors, Christina's key area of focus include healthcare management, program planning, stakeholder engagement, and evaluation. Most importantly, Christina is dedicated to promoting client-centered approaches to care with improved health outcomes and increased quality of life. And finally, we'll be hearing from Dr. Richard Schwartz. Dr. Swartz earned his MD and PhD designations from the University of Toronto. He serves as a clinician scientist and associate professor at the Division of Neurology, Department of Medicine at Sunnybrook Health Science Centres and University of Toronto. A stroke neurologist, Dr. Swartz directs the Sunnybrook Stroke Research Unit in the Department of Medicine at Sunnybrook Health Science Centres in Toronto. He is also the medical director of the Integrated Neurovascular Unit at Sunnybrook and a Northeast GTA Region Stroke Network. And finally, Dr. Swartz is Vice President of Research for the Canadian Stroke Consortium and is the co-lead for ONDRI. Dr. Swartz's research focus is on improving long-term outcomes of people with stroke, vascular cognitive impairment, and vascular contributions to neurodegenerative diseases. And finally, after a few housekeeping rules, the event will be recorded, as you could tell by the announcement a few minutes ago, and will be available to view on our ONDRI YouTube channel and our website. Your cameras and microphones, I believe, were automatically turned off when you joined the Zoom, and you may turn on your camera, but your microphone will remain muted throughout the event. And you can submit all your questions and comments through the chat box, and we will address them throughout the session. And now Dr. Mitchell will share her slides.
Okay, can everyone hear me okay? Yeah, and the slides look okay? They're the right ones?
Yes.
Okay,
Yes.
Good morning, everyone. Thank you so much for the opportunity to speak with you today. It's an absolute pleasure to be here. Thank you to Ruth and ONDRI and the Alzheimer Society for hosting and organizing this very important topic. And I'm excited to share with you some of my thoughts and some of the work that we've done as part of our group on virtual dementia care delivery. And so today I'm going to try and answer for you, is it virtually possible to deliver care for patient population with dementia during the COVID-19 pandemic and beyond? And thank you again for the nice introduction. So I don't need to talk about that any further. I have no disclosures relevant to today's talk. So in terms of what I want to accomplish today for my learning objectives, I want to just describe a little bit about how we had to shift to virtual care in the context of delivering dementia care to our population within the context of the COVID-19 pandemic. I also want to look at what does the literature tell us? So what do we know about how we can deliver care to this patient population? And then finally, I want to talk about what are the barriers and what are potential solutions that we can look towards for the future of advancing virtual care for our dementia population. I'm going to start off by saying before the COVID-19 pandemic, we were facing a large-scale healthcare crisis with respect to dementia care. And everyone knows the slide because a lot of times people talked about this golden tsunami, which is this idea that we have a rapidly aging population and that the prevalence of dementia was increasing exponentially worldwide, with the numbers expected to triple in the coming decades. And locally, this was a significant issue as well, with at least 500,000 Canadians living with dementia, although likely much higher, a lot of unidentified cases, and approximately 1 in 5 Canadians identifying themselves as caring for a loved one with dementia. So this was an important problem before the pandemic. Enter the COVID-19 pandemic, and this, unfortunately, this pandemic disproportionately affected and impacted patients with dementia in many ways. So firstly, having a diagnosis of dementia confers a significantly increased risk of morbidity and mortality related to having the virus and actually your increased risk of death from it. So it adds about a 40% increased risk of death if you're hospitalized with COVID-19. And looking just at local statistics, about 40% of women and 30%, just over 30% of men with COVID-involved deaths had dementia listed as a comorbid diagnosis. So in the context of the pandemic, we really wanted to protect our dementia population from exposure to the virus. What's more is that this patient population was needing care more than ever. So the disproportionate effects of the pandemic were also due to the social and physical isolation of many of our patients and their caregivers. So we saw a huge increase in patient distress and caregiver burnout because the normal supports that patients with dementia were relying on, including day programs, PSWs coming in and out of homes, those were all interrupted. In many cases, they were completely halted. And now much of the burden was shifted to anyone who was in the actual home, or you had patients that were completely isolated. These changes to the normal routine, the lack of social stimulation, and the social interaction, which is so key, not only to day-to-day normalcy, but also towards therapeutic effects in dementia, was exacerbated and came to the fore. So we really needed to shift. We needed to innovate, and we needed to provide care to this patient population in a meaningful way. So how did we do that? Well, we all know we're here to talk about virtual care, and we were receiving guidance from many of our medical associations that virtual care really was the way to safely deliver care within the context of the pandemic. What I have on the left side here is something called the Prochaska model of change, which is the idea that when we're thinking about doing something, we go through a predictable pattern. We pre-contemplate, then we prepare, we act, we maintain. What happened with COVID-19 is that many physicians were in the sort of pre-contemplation or contemplation phase. Many people were interested in doing virtual care, and some of us were early adopters, including myself. But in the context of the pandemic, we were thrust into action, and we really needed to respond quickly. So what can virtual care offer? Well, virtual care can offer quite a bit in terms of providing remote care. So we can provide care directly to patients' homes. Long-term care facilities became a focus, and other third-party locations. And just so we're all on the same page, I wanted to highlight the broad definition of virtual care, which is really the use of technology to facilitate any interaction between a patient, the healthcare provider, and the healthcare system. So that actually spans a broad range of different modalities, including things like telephone, video teleconferencing, like the Ontario Telemedicine Network, the Zoom, and other video conferencing platforms, as well as things like email, e-consults, which is a program to help physicians consult electronically, and then also including things like how we use our electronic medical records, and also remote digital monitoring, which is something I think we're going to highlight a bit further in the presentation today. So when we look at a dementia assessment and we think about how can we actually implement this virtually, we have to think about all the components of a dementia assessment and then consider their transposition. So dementia is an expert assessment. So you need to have an expert of some kind, whether it's a generalist, a general practitioner that's comfortable with dementia diagnosis, or a specialist of many different types. You need to perform a comprehensive history and interview with third-party informants. You need to make sure that that's part of the virtual assessment. And then you need to also perform cognitive testing and a cognitive evaluation, a neurological exam. You need to determine the patient's level of functioning and review relevant investigations. So you can see from this slide that certain aspects lend themselves very well to the virtual realm, whereas others are a bit more challenging and a bit trickier. So this is where our group tried to think about what can we actually do to what's actually there within the literature to guide us, and how can we innovate to be able to standardize the way in which we're providing cognitive evaluations virtually and neurological examinations virtually. So this is a table out of our CMAJ paper looking at cognitive testing for common cognitive tests that many people here might be familiar with, and looking at the diagnostic agreement for performing these tests virtually versus in person, and looking at something called the intra-class correlation coefficient to see how well do we do in terms of diagnosing patients using these tools virtually versus in person. And actually the diagnostic agreement is pretty good for things like the mini mental state exam, the Montreal cognitive assessment, things like the clock drawing test that many people may know. So we started to see that the literature actually supports that we might be able to do this appropriately virtually. With respect to the virtual neurologic exam, the neurologic exam is actually quite a sophisticated and intricate tactile exam. We do motor testing, we test reflexes. So thinking about how are we going to do this through a computer screen was really challenging. So our group, led by some of our residents, actually worked on something called the Virtual Neurological Examination set of videos, which is just a set of instructional videos of how to actually perform this exam virtually. And there are other groups who also came out with some guidance. But when we think about performing the virtual neuro exam in a dementia patient population, there's still a lot of work that needs to be done to think about how we can do this. And this really brings to the fore the idea of these rare dementias. And, you know, having a Alzheimer's disease diagnosis, you could probably perform a very basic neurologic examination virtually based on something like these guidance videos. But when you have something like a Parkinson plus syndrome or another atypical dementia, we need to spend more time thinking about how well we're doing and how we can actually perform this examination, because from personal experience, it's much more challenging. And these are the patients that we're often having to bring in for an in-person assessment. The literature also tells us that diagnosing dementia virtually is actually something that we're quite good at. So there's actually excellent diagnostic agreement between virtual and in-person assessments for dementia diagnosis. Now, this data is actually based on many of the studies the physicians had access to supplemental information, things like formal neuropsychological testing or other in-person outcomes. So we have to look at this a bit closer in the direct-to-home setting and see how well we do in terms of diagnostic agreement. The data also tells us that it's quite feasible to diagnose dementia in rural communities. So we're able to increase our reach in terms of diagnosis. Although again, in this case, many patients access local community clinics and third-party nurses or other allied healthcare providers to help facilitate the interaction. What about follow-up and management? So after we've diagnosed a patient, how do we do virtually in terms of follow-up and management? We know that neurodegenerative diseases such as Alzheimer's disease and related dementias are progressive. And as the disease progresses, there are additional obstacles, things like declining mobility, increasing disorientation and confusion, agitation, and caregiver reliance, which actually make coming into the hospital for increased visits more challenging. Virtual care within the literature has actually shown promise in terms of its ability to initiate and manage medications over time, to connect patient and families with services, to discuss safety and planning, to determine what investigations need to be done, and also to reassess cognitive decline at different intervals. In fact, the literature shows us that we can actually transition between our diagnostic entities. So we can tell when a patient has moved from early stages, something like mild cognitive impairment, to later stages, things like early dementia, moderate and severe dementia. There's also a glimmer that there may be potential added benefits of virtual care, and this is something that really needs to be looked at further. One study suggested that it may improve quality of life over 12 months if patients received virtual care, that patients continued pharmacological treatments for a longer period of time, and that it was quite successful in terms of addressing behavioral symptoms in long-term care facilities. And there's some wonderful initiatives going on around Toronto and surrounding regions, looking at addressing different types of care in long-term care facilities. There's the Long-Term Care Plus model led by Brian Wong and others from Sunnybrook. Dr. Morris Friedman at Sunnybrook is working on his virtual behavioral medicine, looking at responsive behaviors. So there's a lot of opportunity by bringing virtual care into the conversation in terms of follow-up and management of dementia care. What do patients think about it? Well, the literature says that there's actually a high rate of satisfaction for virtual encounters, not just for patients, but also for caregivers and physicians. Things that were cited in terms of potential advantages included time saved, improved access to a specialist, saving money, time, mileage, and of course, those really high parking prices. But what I've described to you sounds great. It sounds like, why don't we all do virtual care? It's got a lot of promise. But where we're really lacking in the literature is in direct to home virtual care, which is really what a lot of us were doing during the pandemic. While it shows that it's feasible and reliable, it really does require caregiver involvement. And this is one of the areas of biggest concern is how do we manage some of the biggest barriers, things like lack of access to technology, lack of technological literacy, especially in an aging population, and lack of in-home supports to facilitate virtual visits. So we also look to the literature to say, is there evidence for any kind of solutions to some of these barriers? And I'm going to spend the next few minutes before finishing talking about some of these barriers. So one barrier is the one that I just highlighted: technological access, literacy, and interference from the different technological platforms. And then, of course, the concern of inequity, that we're actually going to disadvantage certain facets of the population that don't have access to private space, to internet, to even phones. And if we're relying so much on virtual care, are these patients going to be disproportionately disadvantaged because they don't have access? So some of the things that the literature tells us that is extremely important is empowering third-party family, friends, or local health centers, including not just family members that are in the home, but ones that may not live with the patients, to come in and help set up, bring over technology, or having the patient access a local health center that may have access to these technologies, a family physician's office, or another third-party center. Increasing education, resources, and support for patients, especially for patients who are in this frail elderly population. They need a lot more support in terms of setting up a virtual visit and making sure that they have appropriate preparatory materials. So one of the things that we also did, so I worked as a co-lead to a virtual care task force at Sunnybrook, and we created virtual care preparatory materials to make sure that the virtual care visits were successful. So here's an example of some of the materials that we created: checklists for virtual care appointments, making sure that the patients and their family members understood what was needed for a successful virtual visit. When you come into the hospital, that's all you really have to do. You show up and everything else is taken care of. When you're doing a virtual visit from home, there's much more to think about, making sure you're in a private space, there's good lighting, that there's open space for you to walk around to show how well your mobility is going. To be sitting on a chair to facilitate aspects of the neurologic exam as opposed to on a couch or another on a bed. Having that family member immediately available to facilitate technological issues, if possible, and then issues of consent and privacy of information. So this part has to be part of the conversation as well. The next barrier we looked at is the physician-patient relationship. So many of us spend a lot of time in medical school looking at our bedside manner, but how good are we in terms of our quote unquote webside manner? How good are we at transposing our skills of speaking, interacting, empathizing with patients when we do our visits virtually? And the literature shows that we're actually not very good. And we probably now need to work to implement better medical education and training for virtual care. And there's a lot of great groups working at the University of Toronto and elsewhere on trying to bring physicians up to speed. Things as simple as eye contact, which is a fundamental aspect of human communication, is disrupted when doing virtual care. How are you looking at the patient and how are you interacting with the patient? Are you being distracted? Other things to consider are sensitive topics. Can we diagnose dementia or other very serious and terminal diseases virtually? How do patients feel about it? How do clinicians feel about it? I think we need to spend more time looking at and studying this. And then also looking at our own behaviors from privacy and consent and our comfort with those. And then finally, it's the idea of diagnostic challenge, which really brings back this concept specifically of rare dementias, but also patients who are complex medically. Patients, as they age, have increased likelihood of sensory impairment. Hearing aids and glasses need to be used, and patients need to know that they need to be available. Things can get muffled, for instance, by phone trying to do cognitive testing, especially in a patient with hearing impairment who's not wearing their hearing aid. That can be exaggerated and could lead to overestimation of cognitive difficulties. And in fact, the literature suggests that virtual care is probably better for patients who are in the more milder and moderate stages, and severe stages, including those with severe sensory impairment, may not be as appropriate. So we're going to also have to work to triage our patients better and to figure out who's going to benefit from virtual care and who will benefit less. harnessing things like screen sharing abilities for cognitive testing, or having patients print cognitive assessments ahead of time if they have access to a printer, and adapting aspects of the cognitive assessment appropriately. And then finally, it's really important that when us as clinicians are uncertain about our findings, that we document that and that we verify it with in-person assessments, so that we too are learning about virtual assessments and how that translates what we see over the screen versus what we see in person. So that brings me to my summary slide. So the existing literature does suggest that virtual cognitive assessment tools are reliable, that virtual care is feasible and well accepted in the diagnosis and management of dementia. But I think ultimately virtual visits are going to have to be used to supplement rather than fully replace in-person visits. And we're going to have to work towards increasing our data and really studying direct to home visits in virtual dementia care, especially as well for the diagnosis of rare dementias. But this will all take collaboration among clinicians, collaboration among our patients, and collaboration, perhaps most importantly, by our healthcare systems. Things like physician remuneration, things like accessing increased supports and access to technology for seniors. These are things that are going to have to be facilitated in order to ensure that we have a successful future with virtual care in dementia. So this is just my learning objectives, and I look forward to further discussions and comments and questions. Thank you very much for your attention.
Thank you so much, Dr. Mitchell. That was really an excellent presentation. We have many questions, but I suggest we continue along with the next presentation and have the questions at the end. But you can certainly look through the questions now. There were many questions for you. Welcome, Christina.
Thank you. And good morning, everyone. And thank you, Ruth, for the earlier introduction. So today, in respect to talking about our programs and services at the Alzheimer Society in the context of virtual care, I wanted to first talk about our 4 key program offerings to give you a little bit of a background to understand then how we pivoted within the context of COVID-19 and to talk a little bit about what that looked like, and then ultimately the lessons learned and how we'll move forward as an Alzheimer Society across the province. So the Alzheimer Society, our mission is to alleviate the personal and social consequences of Alzheimer's disease and other dementias and to support research. We have 29 societies across the province, and during the context of COVID, we served over 101,000 people living with dementia and their care partners. We have several programs, one pivotal program being First Link, along with the support programs that support that program. And the First Link program is really intended to connect people with dementia to support as soon as possible at point of diagnosis so that they can receive information, supports, and services that will support them not just at time of diagnosis, but across the trajectory of having any form of dementia. The service is provided in a variety of different forms, but certainly usually we provided support in person and by phone. One of our key focus areas in supporting people is to ensure that they reach us directly because through their primary care physician or other providers, because we know that when referred directly, they will connect with us 11 months sooner on average than if they were to self-refer. So for example, if their primary care physician would say, I recommend connecting with the Alzheimer Society, they would likely connect much later than if the family physician provided a paper referral or phone referral. Our other goal is really to ensure that there's continued follow-up on a regular basis so that we can proactively intervene when we start to see evidence that things are changing and some risks are surfacing, so that we can work with families and people living with dementia to know how to communicate more effectively, when to seek out consultation with their physicians, and how to address responsive behaviors and so forth. Another program that we offer is called Finding Your Way, and this program is really intended to raise the awareness of the risk of of going missing for people living with dementia, because oftentimes there are not warning signs in advance. And so we need to help families understand how to prevent missing incidents by creating care plans and safety plans, supporting what to do if someone should go missing. So how do we ensure a safe return? And what do we do to enable all community members to support people with dementia so they can actively participate in their community? And to facilitate this, we have a lot of different resources that we share with families and the public at large, which includes an ID kit. We speak about locating technology. We make connections to Medic Alert Safely Home and other vulnerable person registries. Sorry, my slides are not wanting to advance here. There we go. I just wanted to include this slide to highlight how important this information is, because we have approximately 250,000 Ontarians living with dementia right now. 6 out of 10 will go missing at some point, and half who are not found within 24 hours will be gravely injured or die. And typically speaking, because of the unique nuances of having dementia, 95% of people with dementia are found within 1/2 kilometer of where they originally started from when they went missing. So again, this information is really critical to share at all times, and certainly as well during COVID. Our fourth key program is dementia-friendly communities. And this is really helping people living with dementia to feel included in their communities so that they can engage on a daily basis with grocery stores and various retail and with banking and with different health service providers in a way that they feel respected, included, and so forth. And finally, one other program to mention, we do provide at the Alzheimer Society a whole suite of recreation type programs for stimulation and to reduce isolation. One in particular is called Minds in Motion. And this is a program that provides physical activity, socialization, and cognitive stimulation. And it is for people living with dementia and their care partners. And it typically lasts for 8 weeks, historically in person. So what happened when COVID-19 hit? As mentioned, the Alzheimer Society historically did provide supports and services mostly in person, either in the office or at the family member or the person living with dementia's home, or in collaboration at various sites such as physician offices, family health teams, and so forth. So we immediately needed to pivot to provide supports virtually and by phone. And this required us to invest in technology and to learn how to support our clients to use such technology as Zoom, because we knew that historically clients were not used to using this technology. We provided support online and by phone, and we tailored this so that it would work for one-on-one visits as well as for family visits, so pulling groups together, and for support groups, which is something we had not done in the past. We really also focused on intensity of wraparounds. So as Dr. Mitchell mentioned, with COVID-19, isolation increased, access to resources and supports in the community decreased, stress increased, and so forth. And so we really worked to connect with our clients really frequently to provide a listening ear and to validate the emotions that they were feeling, and also to ensure that they were aware of the different resources that were open, including the Alzheimer Society. Where possible, in collaboration with and in keeping with the public health guidance, we did create opportunities at parks where clients could come together for support groups in person. We did have porch visits, and we did have drop-off of materials, so specifically activation kits, which did include activities for families to use, including puzzles and recipes and so forth, that would help to reduce a little bit of the lack of stimulation. We also leveraged the opportunity to pivot to virtual education. So I mentioned Finding Your Way and I mentioned DFC, and we were able to serve 33,000 people virtually for these very important topics. So still really being able to convey the importance of understanding what to do if someone were to go missing, understanding the risks. And this did extend not just to people living with dementia and their families, but also to providers. So we were still able to connect with police services, the police college, fire departments, mall security personnel, and so forth. But really, what's really important and interesting for us and a really critical learning was related to some of the data that we were able to obtain over the course of this past year. So we conducted an evaluation and we had 2,000 clients respond to the survey, approximately 300 people living with dementia and the remainder care partners. And the results were very much consistent with some of the information that Dr. Mitchell shared. And so I'll read it to you to ensure that I'm not misquoting. But out of the clients that responded to our survey, 65% of people living with dementia and 68% of care partners accessed the online virtual resources during the pandemic, with the vast majority, so 92% for people living with dementia and 86% for care partners, saying that they would continue. The likelihood that people living with dementia accessed an online or virtual resource decreased with age, but age did not affect this for care partners. However, age did not impact the willingness to continue with online programming. So what this means ultimately is that there was a bit of reluctance to access supports, but once the clients were engaged with using Zoom, for example, and received the supports to learn to navigate, the outcomes were actually quite good. And this was surprising for us because we had believed that the online supports would not be as well received as they have indeed been. The other piece to note is that specific to the pandemic, 77% of people living with dementia indicated that the virtual supports provided helped them to cope with the pandemic, and 75% specifically for care partners. One of the noted barriers to support or the impacts of support was that the overall lack of access to supports in the community did increase caregiver burden and stress. So finally, one of the things then that we have acknowledged, actually, before I move forward, I just wanted to share a few quotes here. And so the first quote speaks to the fact that the virtual support served as a lifeline, and this enabled clients to keep in touch not only with staff, but also with the various other clients that they engaged with during the virtual offerings, so support groups and so forth. It was also helpful to provide stress reduction, especially in the context of families that were working within the context of family members being admitted into long-term care and not having access due to visitation restrictions, so helping to reduce that stress. And also through having the weekly support groups, that it was really helpful for relationships as well, because it provided an outlet for those that were really at home 24 hours a day. So for us moving forward, and again, echoing some of Dr. Mitchell's findings, that we recognize that a hybrid will be necessary moving forward. For some, the cost savings, the time savings, the travel reductions and so forth will really meet their needs. And so forth, but we know there are barriers. And so with respect to that, we will continue to offer in-person services once it is safe to do so. And this has created some benefits for us at the Alzheimer Society to really expand our programs and service offerings. And an example of that includes our ability to provide virtual supports across the province. So whereas before, if a person was diagnosed with a rare dementia, or for example, spoke a different language, Spanish or Greek in their community, there might not be sufficient numbers locally to generate the ability to pull people together for a support group in a specific language or for a specific group. And this now is enabling us, because of the comfort and the ability to do so, to pull people together in a way that we have not done so before. Giving an example, we now have an early onset support group running at one of our local societies that is bringing in members from across the province to participate, which is filling a gap that we had historically. So that is our practice thus far, and we'll continue to engage in reviewing literature and engaging our clients to figure out how best to move forward in the coming days and months ahead. Thank you.
Thanks so much. That was excellent. Lots of questions as well on Alzheimer Society. We will attempt to answer all the questions at the end. Now, Dr. Swartz.
Thanks, Ruth, and thank you to the Alzheimer Society for co-hosting this with ONDRI, and it's my pleasure to be here today. And I want to thank my co-presenters for a fantastic talk so far. I hope to live up to what they've led off with. We've talked about virtual physician care, so diagnosis and management, and Dr. Mitchell's talked, and we've talked about virtual access to support in the community through the Alzheimer Society. And really what I'm going to be talking about today is what about research? What about inventing the future of healthcare? What about hope for new treatments? What about developing new interventions? What about finding ways to integrate care in a better way? So virtual care can include not only diagnosis and management mirroring what we do and supporting and augmenting what we do in the office, but there's an enormous potential to collect information and data that can help guide management, because I think we all know one of the challenges with the medical system is persons living with chronic diseases, especially dementia, both patients and family members and caregivers spend 99.9% of their lives not at their doctor's office. So we're going to talk a little bit more about that. The focus today in my overall talk is really taking research embedded in care, that philosophy that we've had certainly at Sunnybrook, Dr. Mitchell, myself, both raised by Sandra Black, medically research speaking. This idea of research embedded in care is a long-standing idea that we've been champions of. And what we're trying to do with HANDS Ontario is to take that to the next level by embedding care in research. And I'm going to tell you what I mean by that as we talk about HANDS Ontario. So I just want to go back for a moment to this graph or this presentation set of figures that Ruth had shown earlier. Laura McLaughlin is on the call here today, and she and Susan Bronskill are collaborators with us in ONDRI that have led this study looking at the reallocation and redistribution of care in the pandemic. And we can see that there was a huge pivot to virtual care. Ruth had alluded to this earlier. I think one of the questions in the chats is, where do people with dementia go? Do they go to neurologists? Do they go to psychiatrists? Do they go to family practice? Well, I think one thing that's really important to look at this is looking at the scale. Per 100 people, you have about 15 visits with family doctors for every half a visit with a neurologist in people who live with dementia. So the burden of medical care for dementia is hoisted heavily in primary care, with subspecialty care by neurologists being a minority. Geriatricians and psychiatrists augment this when you talk about subspecialty care. So neurologists, geriatric psychiatrists, and geriatricians all combine to care for persons with dementia. And the different expertise gets distributed a little bit by, as Dr. Mitchell was saying, some of the more complex symptoms, syndromes, and presentations that people have get sort of distributed, but a lot of it is managed in primary care, and even more of that is managed at home by patients themselves and by family members. In Parkinson's disease, you can see there's a little bit more regular follow-up, roughly 3 to 4 visits a year with a neurologist, and about twice that with a primary care. So roughly almost the same number of total visits, but split a little bit more between primary care and specialty care. And older adults without neurodegenerative disease, on average, don't see a lot of neurologists. They are mainly seeing family physicians. So not that surprising, but important to realize. Just that's one of the key things here to think about is the distribution. There are many fewer neurologists than there are primary care doctors. So that's not surprising. This isn't, this probably reflects mainly the lack of neurologists compared to numbers of family physicians. And so one of the things that we can see is subspecialists are providing a lot more virtual care. Subspecialists are more likely to be further away from the patient. They're more likely to be located in larger hospitals and academic centers where exposure risks, or at least perceived exposure risks, are higher, but also where burden of travel and weighting and exposures and things like that are higher. So you can see the drop proportionally almost to zero, and very, very quickly a lot of virtual care for both dementia and Parkinson's disease. So I think it's important to note that some of this is driven by practice location and exposure risks and patient preferences and so on. I think what's really key is to see in every single one of these graphs, there's a climb back towards more in-person visits. And I think everybody acknowledges, as Dr. Mitchell really eloquently highlighted, the future of medical care is not exclusively virtual. I don't think anybody's proposing that. I think it's an opportunity to supplement. And I think one of the things that she really raised is which patients at which times. And I think one of the things that I'll add to that is which physicians, and this came up in the chat, not all physicians are comfortable with or good at virtual care yet. And I think Dr. Mitchell alluded to that as far as how we train our incoming physicians and the future generations. But there are those of us who have been in practice for 5, 10, 15, 20, 30 years who may be less comfortable adopting to these new technologies. And so just as there's patient preference, there's also physician-based preference, which depends a little bit on their technology comfort, but also on the type of care they provide. So as we move into researching this and understanding how it's going to play out in the future, we really do have to think about all of these factors. So where do we come in as ONDRI and OBI? Just to give you a little bit of context, the Ontario Brain Institute is funded by the Ontario government to help improve the lives of Ontarians living with a brain disorder, to connect research, care, and innovation commercialization through what they call IDPs, Integrated Discovery Platforms. There's nothing in healthcare or medicine that we can't make into an acronym. So here's another one. So these integrated discovery platforms have themes around different brain diseases, and ONDRI is the one that is focused on neurodegenerative diseases. And we really are a connection of clinicians, researchers, patients, innovators, and policymakers. So what does ONDRI do? ONDRI, the Ontario Neurodegenerative Disease Research Initiative, is focused on improving the diagnosis, prognosis, care, and outcomes of persons living with neurodegenerative diseases, stroke, and dementia. This is our focus, and this is what we do. So how do we do that? Well, for the first several years that we were funded, ONDRI was really a deep research study, what we call deep endophenotyping, a fancy word for characterizing neurodegenerative diseases. And we have this Rubik's Cube that we point to a lot, where we collected a very detailed characterized cohort with clinical information, genetic information, 4-hour neuropsychological test battery, gait and balance data collection, eye tracking, looking at how people control voluntary eye movements, detailed structural and functional neuroimaging, imaging of the small blood vessels in the eye, looking at pathology in people who had biopsies or autopsies done. And we did that across different diseases, including people with stroke, frontotemporal dementia, Parkinson's disease, Alzheimer's or mild cognitive impairment, and ALS or Lou Gehrig's disease. And we did that over time, baseline and over a couple of years of follow-up. So this wealth of data is foundational to where we're going, and it's actually a very innovative platform globally. We are an open science platform, which means anything that is not identifiable, so genetic sequences and MRIs are put in a special spot, but all the stuff that can be anonymized, where we can't recognize a face or a genetic sequence and tie it to an individual, will ultimately be released to the world scientific community. And so in the next, hopefully coming months, this first face, the baseline data from ONDRI, is going to be released to the world. And our ONDRI researchers in Ontario and clinicians have already been hard at work analyzing a lot of this data for comparisons across these cohorts or within these cohorts, making discoveries that I would love to talk about, but don't have time today, but certainly happy to answer some questions on that. This is sort of foundational. And it's important tools that really have ensured the success of ONDRI. One of the key ones I want to highlight is the Patient and Community Advisory Committee. This is made up of care organizations like the Alzheimer Society, Heart and Stroke, and so on, but more importantly, made up of persons with lived experience with these diseases and their family members or caregivers. And these volunteers have actually been absolutely essential in the last 5 years of ONDRI as we've moved from this foundational study to HANDS Ontario in the future. We've also built a platform for secure data collection, anonymization, sharing and release, and ensuring the really, really high quality of the data that we collect. So all sorts of pipelines to ensure that the data is usable after our patients have, heroically volunteered a lot of their time and energy to help us collect this kind of data. Those platforms and that learning are really the setup for the HANDS Ontario study. So we've taken what we've done in this deep characterization study, and we've said, how can we move this towards accomplishing the quadruple aim? The quadruple aim is sort of a health economic speak, where we want to get better outcomes for people, better patient experiences, make it easier on clinicians, get care more accessible, and lower costs. So we want win-win-win-win-wins. And that's not easy to achieve, but it's really important, and it's dependent on the involvement from the outset of people with lived experience. And this is one of the things that's foundational. So HANDS Ontario stands for Health in Aging and Neurodegenerative Diseases and Dementia in Ontario. So that's the HANDS acronym. And what we're really looking at is a new research study that is not only embedding research and care, but trying to embed care right into research. We're saying, instead of having people come in several times for a day or multiple days to do 4 hours of neuropsychological testing and 2 hours of gait and bus test, so on, we want to start to develop research questions and data collection that will not only help discovery, but that will help care. And this is what we mean by embedding care in research. We want to start to identify and develop tools that have meaning for patients and physicians. We all wear wearables. There's a technology revolution right now where there's a lot of widgets. So I got my iPhone, and often that's in my pocket, and I got my Apple Watch or your Fitbit or whatever. There's a lot of access to these kinds of data collection tools. The problem is all of these widgets collect data without actually understanding why individuals, patients, family members, or physicians might want to use that data. And HANDS Ontario is really looking at saying, how can we make this data useful for you? So, okay, we can give you your heart rate. Well, if we detect an irregular heartbeat, that's useful for you and your physician, because maybe you need a blood thinner to prevent strokes. Okay, that's good. Fitbits and Apple Watches can already do that. But what if we could collect your heart rate and blood pressure in the real world, so that people who have white coat hypertension, when they go to their doctor's offices, aren't overdiagnosed, and we could get a sense of how much that's fluctuating. So some people have a high blood pressure at the doctor's office, but later in the day get really low blood pressure. So when we give them medicines, maybe we're making them too lightheaded. Some people have, in Alzheimer's disease and some dementias and Parkinson's disease, they have the autonomic nervous system that controls blood pressure goes a little bit off. And so people can have big fluctuations in their blood pressure. That's not something you measure at one visit in a doctor's office. What if we could use watches and wearables to track that and collect that kind of data? What if we could actually tell you about it and tell your doctor about it? What's happening in the real world at your home, or when you're going to the grocery store, or when you go to your grandkids at night, what's happening to your blood pressure? What if we could use that same kind of data to measure not just your activity and step counts the way that the Apple Watches and the Fitbits do, but collect data about agitation or how often people are wandering at night? We heard excuse me, from Christina about wandering and missingness. What if we could actually give caregivers information and physicians information about just how often people are getting up and wandering through the house at night? Would that be helpful? Could we actually use that data to actually make strategic changes in the environment, in the medications, in interventions that would help persons with dementia sleep better, for example, or wander less? So that's the idea behind moving this kind of rigorous data collection, rigorous standardization, seamless, secure data and global access or release to researchers, these kinds of foundational pieces from ONDRI, but move that to where it matters, into the home, into the community. That's what HANDS Ontario is all about. And can we use the virtual care tools to facilitate that? So for persons who are not comfortable online, we can speak by phone and we can collect all sorts of data. We can get consent remotely so people don't have to come in the context of a pandemic. If people are able to come in, if the pandemic is easing off, we could do in-person assessments. If people are comfortable, they can actually go online and fill out their own forms and provide data. So the idea here is we are going to be collecting data across 3 levels. We're going to be collecting a blood sample that will give us data on genetic risk factors, but also proteins in the blood that could indicate diagnoses, that could indicate Alzheimer's disease pathology, that could indicate alpha-synuclein potentially, which is seen in Parkinson's disease. We want to see if we can push the boundaries in what we can discover non-invasively through simple blood tests. And we want to be using genetic and protein markers to help us relate those to actual behaviors, to gait, to activity, to blood pressure fluctuation, to agitation. We want to see if we can actually identify these kinds of signatures in free living behavioral profiles. We want to look at how this multidimensional data, the blood samples and the wearable data, and I kind of alluded to this earlier, but the wearable data gives us multiple levels of data. When we're wearing more than one sensor, we can get basic physiology, like we talked about heart rate and blood pressure. We can get more advanced physiology, like circadian rhythms and wandering and blood pressure variability. And then we can even get some behavioral measures of things like agitation, or fluctuations in what we call levels of arousal, how agitated or sleepy people are, which can indicate things like delirium, risk for infection, risk for falls, and so on. So we're going to be collecting the blood sample, the wearables, and we're going to be linking that to the data at ICES. You saw some of the power of that administrative data earlier when we talked about virtual care, to look at how often people are going to the hospital, how often people are falling, how often people are visiting emergency rooms, how often people are needing to be placed in institutions or access respite care, and see if we could actually start to identify markers before those problems happen. Markers that we could identify in the real world, in the home, in the community, that could then be little red flags, almost like people putting their hands up to say, something's going on, we need some help here. To spare needing respite care, to prevent emergency room visits or falls. This would be the long-term goal. And the other key piece is we don't want to just be widget makers. We want to work with our patients and caregivers and community agencies to actually say, what works for you? Is this useful? Are people tearing it off? The reports that we're giving you, the feedback reports about activity or blood pressure fluctuations or nighttime agitation, are those useful? Could we present that in a different way? What would be helpful for you and what would be helpful for your physicians? So this is the third goal within the HANDS Ontario platform study. And so we're going to have these core minimum data elements where we're collecting blood, we're wearing these technologies for 1 to 2 weeks, we're linking to the data, the administrative health data at ICES. We're asking for permission to contact you again to get your feedback and to iterate these reports and make them more and more useful over time. And we're going to be doing that across neurodegenerative diseases. That's the core study. That's happening in everybody. On top of that, we will be layering some sub-studies where, for example, individuals with Parkinson's disease may do an additional piece. They're going to wear the devices when they're in hospital doing what's called a dopamine challenge test, an L-DOPA challenge test. And then they're going to repeat that at home to see if we can collect the same data as accurately, as effectively, and maybe spare people in the future from having to come into the hospital to do levodopa challenge tests. If it becomes something that can be done at home more easily, it could even be done more frequently, less expensively, more safely, more comfortably for patients. In ALS, the ability to detect falls, to detect clinical decline, potentially even to detect choking or aspiration. There's going to be a sub-study specifically looking at ALS, because this is a disease that unfortunately progresses very, very quickly. And so when you can only see your physician every 6 months, and the average disease course is 2 years before death, that's not frequent enough check-ins. And if we can use remote data collection to provide more frequent monitoring and identify problems before they happen, we might be able to improve quality of life and potentially even to extend life by preventing complications. We're looking at whether these approaches can be used in long-term care and in the community in people with dementia and Alzheimer's disease to help caregiver data collection, to give ammunition to family members when they go to the doctor's office, to be able to quantify behavior changes, sleep problems, wandering, which would also then give us a target that we can use potentially in the future. This might be a sub-study that it will come in the future, but to say, can we actually do pre-post interventions? Right now, we're really working on characterizing the reports and so on. But if we can actually develop these to be reliable, useful metrics for people, you can have an agitation index or a wandering index, then try an intervention, try a behavioral change, try an environmental change, try a medication change, and see what its impact is on those same measurements, which start to put the locus of control in the family's hands as well as the physician's hands. And it gives the physician and the family data on what's happening in the real world, not just when you're at the doctor's office. Because a lot of people say, oh man, I was at the doctor's office, but it was a really good day that day. And the other 6 months, they were really having trouble. So people do rise to the occasion when they come to the doctor's office. So one of the reasons, excuse me, why I'm really excited to be here talking to you today is we do want people to volunteer with us to help us understand your own health in the real world. And this study is really designed with and for you. So we do want to acknowledge our patient and family, our PCAC, our Patient Community Advisory Committee. This study was co-designed with them to use these latest technologies, virtual care type tools, in a different way than the diagnosis and management that Dr. Mitchell was talking about. This is really to accelerate research in the home, in the community. We'll be providing these reports, and there is the altruistic benefit of helping us improve future care and improve understanding of disease. That's why we're collecting the genetic data and the biomarker data in the blood to try to really see if we could advance both the science and the care at the same time. Again, going for that quadruple win. You wear the wearables for 7 to 10 days. We do 1 blood test and we fill out questionnaires. That's the commitment for the study. It is eligible to healthy adults as a comparison group, people after stroke, with or without a neurodegenerative disease like Alzheimer's disease, mild cognitive impairment, ALS, Parkinson's disease, or frontotemporal dementia. If you or a family member are interested, we are getting set to launch the study over the summer and really accelerate enrollment in the fall. So we're just finalizing contracts with Life Labs and Research Ethics Board. So we're a few weeks away from enrolling our first participants. But we are welcoming people if you're interested. HANDDS@ONDRI.ca. You can visit our website, or you can call this number, the 437-882-8335. And we would be happy to give you a call back and sort of set things up for you. As soon as we go live, we'd love to have a list of people who are interested. And even if you just have questions and want to talk further about it, please feel free to email us or call us, because this study will not be possible, obviously, without people willing to volunteer and interested in the kinds of data that we're able to provide. So this was a bit of a whirlwind tour of ONDRI globally and the HANDS Ontario specifically, the HANDS Ontario study specifically. We're hoping that this is kind of the future of neurodegenerative disease and dementia research, where we can start to bring the clinic into the home and embed care into research. Thanks very much.
Thanks so much, Dr. Swartz. I'm wondering if we could, we are late, it's 11:06, but I'm wondering if we could sort of pick up on a couple of the questions through either yourself or Dr. Mitchell to answer some of the questions, or Christina, if but I think you've answered some of them through the chat box. So, I mean, the first question was about the drug that's been potentially approved in the U.S. Maybe you can address that.
Yeah, the aducanumab. This is a bit of a controversial drug, and this is a whole other talk. Dr. Mitchell, I think, will have a lot to say on it. From a research perspective, I think one of the things that's really interesting is it's not clear to me whether Health Canada will approve it completely for clinical use or whether they will approve it for use in the context of more trials. In the US, they are requiring more trials, but they're requiring long-term trials that are going to take 7 to 10 years to complete. So it's a little bit of a gray zone what's going to happen here. The HANDS Ontario study would be an ideal platform, for example, to and we're kind of hopeful that if it does get approved either for clinical use or as the context of a clinical trial, we could use these kinds of wearable biomarkers and potentially serum markers to examine the impact of the medication to help make the case for funding it more thoroughly if it's a sort of a conditional approval. So from a research perspective, we kind of have to see what Health Canada is going to say and whether there's asterisks or holds or conditions on this. Sarah, I don't know if you want to speak to it from a clinical perspective.
I would just echo what was already said in the sense that, we're all, waiting on bated breath for the next treatment for Alzheimer's disease. There's a lot of us who are concerned about this particular treatment in terms of the data that's available at this moment. This medication has received conditional approval in the US based on actually having more data because the studies that they've done thus far were actually stopped early because of futility. And then it was basically looking back at the data in a different way that led to this. And so we just want to make sure that we have effective and safe therapies before we're recommending them. So I know you've waited so long, but we have to wait a bit more and give this time to become a bit more clear before we know how to properly, advise related to this medication, potential treatment.
Great. Okay. There was a question on gait and brain lab and the evaluation that's done there. I don't know if there's anyone could comment on the gait and brain lab.
Just going to say it's great that they're following you so closely. I think that's another sort of a research embedded in care approach as well, I believe. There were a lot of,
yeah. Sorry, I was going to say if you look through comments and see if there's any we can answer, or else we'll finish up today.
There's a lot of helpful suggestions from the Alzheimer Society as far as some programs that are ongoing, younger persons with dementia, but also community programs for dementia more generally. As far as lifestyle interventions, Christina was highlighting some of those. Mary was asking if a patient needs to be seen by a neurologist and have scans every year. Sarah, I'll defer to you there. I think annual scans are not a routine part of our care in either stroke or dementia, but regular follow-up by a physician, if not a neurologist, is absolutely important.
Yeah, absolutely. And just a couple other things to touch on quickly here. So I love this one about closed captioning for Zoom, just in terms of the virtual care. I think that's a really important kind of advocacy piece that I think would be really nice to get maybe the Alzheimer Society or some of the hearing impaired institutions involved in to try and advocate for. I think it's a really nice idea. I think Dr. Schwartz talked a little bit about the fact that psychiatrists, neurologists, geriatricians, family medicine doctors all treat patients with dementia and sort of focus on different types, but all have a lot of intersecting. And then I just wanted to touch on a couple of the virtual care related comments. Shelley had written that, her physician is more interested in a phone appointment than the virtual video visit. And this speaks a bit to what Dr. Swartz mentioned, that it's not just about the patient preference, but it's about the physician preference. And so we are working on some continuing medical education about virtual care for physicians who are not as comfortable. And we're going to have a lot of work to do on matching patients to the appropriate mode of care delivery, phone follow-up, video follow-up, in-person follow-up, initial assessments. So you bring up a really good point there, that what's offered doesn't necessarily match the needs of the patient. And so there's work to do there.
Sarah, just along that point, if I can just, I want to attribute a phrase to you. Sarah and the team at Sunnybrook really emphasized early in the pandemic that the concept is virtual first, not virtual only. So especially in the pandemic, it was, we're going to default to an initial virtual appointment, but that's not at the exclusion of ever seeing somebody in person. And that's sort of what the group at Sunnybrook across diseases has really embraced. That this is really about a way to triage, not an exclusive modality of providing care. And I think as the pandemic numbers drop and reopening starts to happen, it's going to be really interesting to see if do we still default to virtual first, or is it now, as Sarah's kind of alluding to, virtual by choice. And then who, when, what, it gets almost more complicated. When we're all in lockdown, it was almost easier because your choice is don't come at all or come virtually, and then we'll make exceptions if we have to. So it's going to get more complicated before it gets simpler again. But the idea of virtual first, not virtual only, even in the peak of the pandemic was I think key.
Yeah, I completely agree. And virtual care has, in a sense, a triage component to it, you know, getting at least access to the patient and then determining the next best steps.
Yeah,
sorry.
I was just going to say in our stroke clinics, we pivoted across a day because I was already providing remote care as subspecialty access to remote communities and so on. And one of the things that we found consistently, and I think Shelley is highlighting this, I'm certainly offering this to my patients. The choice between Zoom, phone call, or in person, as in person starts to become more available. Right now, it's been more, do you prefer phone or video? And we're going to now have the menu of all three. And I think it's a mutual choice, right? It has to be both. So there are some things that patients may prefer to do virtual, but I'm saying, no, medically, I want to see you. I think I'm worried about you and I want to see you in person. Even if it is a little less convenient for both of us, I want to see you. And so I think we have to recognize there's a culture shift now that has to happen, that we've never had to sort of negotiate the venue before, right? And now we have to have a whole, at least mutual assent or quick thought about how are we going to do this. So this is going to be a really fascinating thing, I think, over the next year, is how does that happen? It may be pretty quick for most people, but there may be some cases, especially when there's new symptoms, in a dementia patient who's declining. We've seen some things in the chat, about people becoming nonverbal or not walking as well. Those are kinds of things, Sarah, where we often prefer to see the patient in person if there's been a significant change. So once we're more opened up, those may be the kinds of things we say, no, come in. Or if it's going to be a long time, we say, okay, we'll do a quick virtual first, but we're still probably going to need you to come in just to triage if we need to send you to the emergency room, or we can wait a few weeks to see you in person, right? So I think we're going to see that blend. And as Dr. Mitchell highlighted, it's going to be partly dependent on patients, partly dependent on doctors, and partly dependent on the government and what they allow, what they fund, how they regulate. What moves forward. It's going to be fascinating, I think, for the next couple of years as this plays out.
Very good. I think that's probably the bulk of the questions answered. So, so once again, thank you for joining us, and thank you so much for our great presenters. And feel free to reach out to us. As I said in the chat, info@ondri.ca. if you've got any follow-up questions, or hands@ondri.ca. And we will send the recording out in the next week or so. So you can watch the presentation again if you'd like to.
If George is still on, I want to throw out there, Lewy body is another disorder of interest. The thing about Hands Ontario is we're taking people where they're at. So whether they present with Lewy body, present with Parkinsonism and develop Lewy body symptoms, present with dementia and develop Lewy body symptoms, those overlap conditions, both Lewy body and stroke, contributing to Alzheimer's or Parkinson's are very, very common. So stroke is actually one of the most common comorbidity, Lewy body second most. Both are very, very prevalent, and we're interested in both of those, both as far as virtual care and within HANDS Ontario. So please do reach out. Thank you again, Ruth.
Thank you very much, everybody. Enjoy your day.
Thank you, everyone. Thanks for having me, and thanks for putting on this great talk.
Thank you.